Volpicelli works at the Department of Emergency Medicine at the Hacienda Ospedaliero. I hope I said that right.
San Luigi Hospital. San Luigi Hospital.
San Luigi Hospital in Italy. As we all know, Professor Volpicelli is an expert in ultrasound, lung ultrasound. Currently, he does research in emergency medicine and point of care ultrasound. We just read his article in the intensive care medicine. We just published, just come out of the autumn. Professor Volpicelli, thank you very much for joining us.
Thank you, Carlos. Thank you for inviting.
So I wish to start with getting a notion of the current situation of COVID-19 patients in Italy. We've all heard about this very disastrous situation that you have in Italy with a lot of people dying every day. Yes, exactly. Can you tell us about your experience with COVID-19 patient during the Italian outbreak?
We are just living a difficult moment that started more or less 3 weeks, 1 month ago. And we are experiencing the arrival in the emergency department of a lot of patients with respiratory symptoms. And the point is that this outbreak totally changed the hospital because we, time by time, needed to reallocate the patients and to transform the hospital. And nowadays, is totally dedicated to COVID-19 patients. So what I saw is just a transformation of the hospital in a really short time. It became totally a different hospital. We don't see anymore other pathologies, just a few, and there is no enough place to allocate our patients. Needing oxygen in high amount. So the hospital has a problem with the shortage of oxygen, shortage of devices for ventilation, and also shortage of places to allocate the patients.
I can imagine this difficult
situation. Do you wanna some more?
No, I think we get the picture, and besides, it's all over the news and the social media, where Italy is very ground zero for Europe, and very difficult situation. Our hearts are with you right now, and all the doctors in the first line. Thank you for all your work. Can you tell us how lung ultrasound has helped you during this crisis?
Well, lung ultrasound is really crucial because just to say in a few words, what is happening is that lung ultrasound is literally guiding diagnosis in the front door, and also it is guiding the triage of patients, but even more, once the patient is admitted to the hospital in the ICU, for instance, or in the emergency department, lung ultrasound is literally guiding the strategy for ventilation. And this is happening more and more. At the beginning of this outbreak, we were usually doing other chest imaging, like chest X-ray and especially CAT scan. But then, time by time, for the reasons that I think we will explain later, we abandoned all other chest imaging techniques. So we are not performing chest X-ray anymore. and we are time by time reducing the CAT scan to a minimum, only reserved for some condition and some patients. And lung ultrasound became the main imaging technique. I can say the first intervention in our patients before using the stethoscope. When we receive the patient, we just perform lung ultrasound.
I think this is a very important point because we see other specialities like the pneumologists who constantly ask for CAT scans in these kind of patients. Do you think that you can get the amount of necessary information, probably not all the information, but the necessary amount of information for triaging these patients with just lung ultrasound?
Of course, using CAT scan as a standard imaging is not possible for the simple reason that you cannot afford the management of these patients, transporting all these patients to the X-ray facilities, because there is no time, because you increase the possibility of cross-infection. You must consider that when you perform a CAT scan, it's a problem because after the CAT scan has been performed, you need a team of many persons, at least 2 persons, to clean up all the area of the CAT scan and all the device. And the other point is that what we noticed is that CAT scan does not add anything to the first management of the patient, because of course it is very helpful in making the diagnosis of pneumonia, but there is no need, because lung ultrasound is enough. Why it is enough? It is enough for the simple reason that this disease is due to the virus, the SARS-CoV-2 virus, as you know, has a great and strong tropism for the low airways. And what it has noticed that this virus gives a kind of pneumonia that is mainly distributed in the periphery of the lung. And as you know, the periphery of the lung is very well examined by lung ultrasound. So when the patient has pneumonia, most of the time, I may say a high percentage, very high percentage of these patients can be diagnosed by lung ultrasound. There are only very few cases, never happened to me, never, but in literature has been described very few cases of positive CAT scan and negative lung ultrasound. Whereas it is totally common and very, very common to have negative chest X-ray and positive lung ultrasound. That is the reason, the main reason why we totally abandon the use of chest X-ray.
I think you're correct in these points. I think we also use a lot of lung ultrasound here in our ICU in Fundación Santa Fe in Bogota, and we can see over the years that we've practically abandoned chest X-rays. Very few chest X-rays we use now, and what the information that we cannot have with lung ultrasound, which is again very few cases. I think that you need to go for a CT scan right away. Did you build a lung ultrasound protocol to triage these COVID-19 patients in your hospital?
Yes, we are using a protocol. Of course, it's not easy because what is happening, and it will happen, I think, in any place where the outbreak will start. What is happening is that we need experience. So time by time, the way we manage changes, and we improve day by day, just watching what is, observing what happens, knowing the disease that is totally, at least for us, a new disease. We didn't, for instance, we didn't experience the outbreak for other virus, like it was in South America, I think, and in Asia, for instance, for the MERS and the S.A.S. that happened years ago. So for us, it's totally new. And we need to learn day by day. So our protocol changed. And I can say that nowadays, the protocol we use, in my opinion, is the best that you can apply by integrating lung ultrasound. This protocol starts from performing lung ultrasound in the patient. It's the first thing we do.
And how exactly do you scan these patients? What is exactly that you do?
The protocol is going to be published very soon in an important journal. So it will be something that will be really detailed in the publication. Anyway, to give you an idea, we scan, of course, you need to scan anterior, lateral, and posterior chest. And this is because the disease can be spread everywhere. So it's not enough to scan only one area of the chest. What we do is we perform 5 videos per side. And these 5 videos are in longitudinal scan, the anterior chest. Each video is about 8-10 seconds. That is calculated the time to have enough idea of what is going on in that part of the chest, so including all the intercostal spaces. So we do 1 video 10 seconds in the anterior chest, longitudinal. 1 video in the lateral chest, longitudinal. 1 video to check the effusion in the base of the lung, lateral. 1 video longitudinal in the posterior chest, superior, in the area between the scapula and the spine. And then 1 video jumping from one intercostal space to the other in the area below the scapula, posterior, so the inferior part of the posterior chest, this time in oblique scan. So we do oblique scan of all the intercostal spaces that are allocated in the posterior chest below the scapula. So we perform 3 longitudinal scan videos and 1 oblique scan videos per side, plus 1 video for effusion. So 5 videos per side. I think this is the best way to have a comprehensive look at the lungs without doing something that is too, takes you too much time in a moment when you will have a lot of patients to visit. And at the same time is the best way to have recording the exam, to have the possibility to review the exam after the visit. That, in my opinion, is very important because it can be important to fix a quantification of the disease and also to monitor the disease during the hospital stay.
Yes, I must. Sorry, please go on.
No, the other point is that this is something that works if you use the convex probe. And why the convex probe? Because it is wide enough, the surface of emission is wide enough to include in the same scan a large part of the chest wall of the lung surface. And also because it has a good penetration, so enough penetration to let you study and examine the vertical artifacts. Because the vertical artifacts, so B-lines in all the forms of B-lines, is the main feature of the disease. Because this disease is mainly interstitial. It is also alveolar, but it's mainly interstitial. And the interstitial patterns are the most important signs in this disease. So you need a probe going enough in depth and with a low frequency, giving you good resolution to the analysis of a vertical artifact.
I just saw a tweet you made on Twitter, and I'm going to read it for you. And and I quote: "After having examined personally hundreds of suspected COVID-19s in the storm with a growing percentage of positive, I feel the necessity to simplify the technique for lung ultrasound and ask the community to abandon complexity and philosophy." And I just wanted to ask you, what do you mean by this? Did you think that this new protocol you are seeing is less complex than we've seen in your previous guidelines?
No. It's not about my guidelines. I hear repeat that this disease is something totally new. So what we fixed in the consensus conference and in the literature in the past was dedicated to ordinary diseases. So pulmonary edema, IRDS, and in this case, there are some novel messages that we should give. And the first message is that you need something simple. So you need a way, technical way, to look at the lungs in a short time. That can be done by anyone. For instance, I tell you that if you use a different probe, like for instance, the linear probe, you need to be more high skill to understand the image. The same is when you use the probes with a small surface of emission, like the microconvex probe and the cardiac probe. You need more time to perform the whole examination. So choosing the convex probe is a simplification of the technique. Using just 4 videos, 4 or 5, including the one for effusion, videos per side is a simplification. And also another simplification that is very important, that in my opinion is very crucial to understand that we are facing a new disease, is that it's not, in my opinion, so much important to differentiate consolidations and interstitial patterns. This is what we were using to do, for instance, to monitor RDS. And in that model, it's okay, it works. But in this disease, I don't see, in my opinion, any difference between the severity of the pattern when you have consolidations, yes or not. There is not so much difference. I see many patients going very bad, showing just B-lines, and on the opposite, many patients going very well, recruiting very quickly, and recovering also quickly, showing a lot of consolidations. So it is different in this disease. This is my observation, of course. The consideration of all the differences that we fixed in lung ultrasound, and this is a way also to simplify.
Yes. So what I can try to understand of what you're saying is that this is a completely new disease that didn't have before, and that the pattern that we see in lung ultrasound is mainly B lines plus a thickened irregular pleura.
No. I take this occasion to clarify something about the pleura, because I see many times reporting about thickened pleura. There are two points that need to be clarified. First, the pleura is not thickened. I mean, you can even see a pleural image that is thickened in the in the screen, but it is not corresponding to a real anatomic thickening of the pleura. So what we see in the screen about lung ultrasound is just an image that is an artifact image, and gives you the information that the pleura is there, because it's the place where there is the highest interface, the strongest interface between air inside the lung and the tissue of the chest wall, but it's not a real anatomic image of the pleura. So if you measure that line, you just measure an artifact, and thickening is not the right terminology. The right terminology, rather, is irregularity of the pleural line. And this is an aspect that is very important. The second point is that, okay, we observe irregularity of the pleural line, but this has no meaning, because the irregularity of the pleural line cannot be observed without B lines. So the main aspect are B lines. Then you can see irregularity of the pleural line. But this disease is teaching us that even without irregularity of the pleural line, there are B lines. You understand what I mean?
Yes,
So,
yes.
So if I have to describe the pattern of this disease, I may even say that there is irregularity of the pleural line in some part of the lung. But it is not crucial, it's not important. What is important, what matters, is the presence of patterns of B lines, clusters of B lines with some specific aspect. That is what we are trying to characterize and study. I would say even more. When I see irregular pleural line with B lines, it is difficult for me to distinguish from other diseases in S.A.S, in fibrosis. Whereas when I see in an acute situation of patient with fever and cough, in this moment, in this historical moment of the pandemic, when I see a regular pleural line with many B lines, very shining and confluent, this is typical of the COVID-19 disease. So this is the reason why irregularity of the pleural line, even worse, thickening of the pleural line that does not mean anything, is just confounding the persons, because it's not the point, it's not the main aspect that should be pointed out.
Do you? I just saw that in Milan they had just done 50 autopsies of patients with COVID-19 disease. Do you think there is a correlation? What they found? They found mainly very congested lungs with infiltration and exudative fluid, and infiltration almost ARDS like. That was my feeling when I read the report. Do you think there is a correlation between these autopsy findings and what you find in lung ultrasound, what you just said?
No, I really, to be honest, I don't know this data. what I can tell you is that there is a tight correlation, and this is for sure, about what they saw in China and even in Italy they are observing in CAT scan, and what we see in lung ultrasound. I think that we should be very careful in comparing and studying, investigating the disease in autopsy, because in autopsy what happens is that we have a look of the very advanced phase of the disease. So people dying, they probably have a situation that is not isolated, but these people, they die for cross infections, for a lot of the storm that is caused by the disease, that is not only the viral infection. I am much more interested in the correlation with the CAT scan aspects of the disease that is done in the same moment with lung ultrasound. And what I can tell you that is there is a very tight correlation between the aspect of CAT scan and what we see at lung ultrasound. And the main aspect in CAT scan is the ground glass opacification. That is, I don't know if you observed some CAT scan from patients.
Yes.
It's absolutely typical. When after you will gain experience with patients, when you will have a look at the CAT scan, you will say, okay, this is COVID-19, just in 1 second. And the same is with lung ultrasound. It is exactly the same. And the main aspect is the ground glass opacification. Then you have also, of course, consolidations. You may have consolidation, yes or not. You may have crazy paving. Crazy paving is a more advanced alteration than ground glass, because crazy paving is the ground glass opacification plus thickening of the interlobular septa, giving the aspect of the paving that is called crazy paving. So you may have crazy paving also, but the main aspect, the main feature is ground glass. And the ground glass in lung ultrasound means a storm of different shape of B-lines, with and without irregular pleural line. I may say in lung ultrasound language, even more specific without irregularity of the pleural line, because it is more specific of a very acute situation that is evolving, that is very early observation. I think, I have no data to tell that, but of course I think that the very early alteration of in the disease is the ground glass, very mild ground glass, then evolving to crazy paving with irregularity of the pleural line, then evolving in consolidation. But it's only just a matter of timing of the evolution of the disease.
So this is a very important take-home message, what you're saying, because this means that we can see an evolution of the disease and probably classify the patients in timing. Let's say that if some patient comes to the emergency department with some fever and cough, and maybe I can choose to hospitalize the patient or sending home. Do you think this is possible?
For this topic, I think I will disappoint you. I think there is no way to classify and to predict a disease that is totally crazy. This disease is not possible to classify for the simple reason that when the disease starts, you have already in your eyes, that is a characteristic of the disease, all the different stage of evolution of the disease, with the consolidation in one area. In the other area, the B lines coalescent with the regular pleural line. In the other area irregular pleural line. So it's totally out of any control, and you cannot classify the evolution of the disease. And also the other characteristic is that the disease is totally spread all around in a patchy, totally patchy distribution. So very crazy distribution. In the posterior chest, I read that they say, someone says when it is in the posterior chest is more severe than. It's not true, because I saw many patients with the posterior chest totally spared, totally healthy, and the anterior chest involved by the disease. So there is no rule. And there is, in my opinion, there is no way to predict who is the patient that will go well and who is the patient that will die or will need intubation. It's totally out of control. This is the reason why this disease is very dangerous, because the risk every day is to under triage patients and also to over triage patients, because we have no possibility to distinguish and to predict. What we are finding, and this is something, in my opinion, something serious, is that there is anyway an evolution in time of the disease. So when you observe a patient with a certain degree of spread of the pneumonia that you can observe by lung ultrasound, that I can say is, just to give a number, 10. And this patient started the symptoms 2 days before. And then you have another patient with the same situation at lung ultrasound, so 10, same number, 10. But he started the symptoms 15 days before. Then what we can say is that probably the patient who started 15 days ago is safe, is in a safer situation than the other one.
Yeah.
So the message is to be careful when you perform lung ultrasound and you diagnose pneumonia in patients at the very early phase of the disease, and be more, more relaxed with patients with a long story of symptoms, cough, fever, malaise, and so on, in the same aspect of a lung ultrasound. And this is, in my opinion, the only thing that we can fix and we can say.
Very important message. So individualize each patient and try to act accordingly. So in your experience, which I see it's a very advanced experience, what kind of patient have you scanned? I mean, I'm trying to go to maybe very old patients, very young patients, pregnant patients.
Sorry, I lost your voice because I removed the sound from the headphones.
Yes, I asked that in your experience, have you scanned different types of patients, maybe old patients? Are they different from younger patients or from pregnant patients, or maybe even children? Is this something that you see?
Sorry, just one moment, because he's asking for my password to continue the connection. Just one moment. I don't know why. First, I have no experience at all with children.
to be honest, I never saw children. It seems to be a category of the population that is safe, that is not so much touched by the pneumonia. Probably they are infected. A lot of children are infected, but they do not develop pneumonia so frequently. I just heard some cases in Great Britain just recently of one child of 5 years old died for pneumonia, and two boys, I think 13 years old and 15 years old, died in London. But in Italy, we have no, I can say that we had not so many cases. So I didn't observe children. And I didn't observe pregnant women. So I cannot tell you. I have no experience at all. Regarding all the rest of the population, I can say that we are observing patients of any age. At the very beginning, it seemed to be more a disease for elderly patients with other pathologies, chronic pathologies. But then, time by time, what we observed is that the age of the patients went down very, very quickly. And now we have patients of any age, from 20 years old to 25 years old to any age. I may say even that the elderly patients reduced the number, because probably they were the first part of the population made aware of how much dangerous is the disease. So they were the first persons to isolate themselves in the houses, and now we are observing more young persons. We distinguish 3 phenotypes, and it is crucial to combine the information from lung ultrasound and the phenotype. But these 3 phenotypes are very simple. The first is the patient with respiratory failure. So any kind of respiratory failure. They come to the hospital with dyspnea on exertion, or even with severe distress. All these patients, of course, may manifest or not signs of pneumonia. And what I can say is that when a patient with severe respiratory failure has no signs of pneumonia in lung ultrasound, you can rule out COVID-19. It is not COVID-19. The second phenotype is the patients with very mild or mild symptoms and no respiratory failure. This is the vast majority of patients coming to the emergency department. In these patients, a negative lung ultrasound, so no pneumonia, means that the patient has no pneumonia, but probably has the infection. And what we do is we perform these swab tests and we discharge home these patients. And then we contact the patient to confirm the disease, so isolation or not, depending on the result of the swab test. The third phenotype is the phenotype of patients with other diseases, so chronic diseases, respiratory diseases, like, for instance, severe COPD or fibrosis. We are observing a lot of patients with fibrosis and the possibility of COVID-19. Cancer, and also cardiac chronic diseases like heart failure, chronic heart failure, cor pulmonale. All these patients are classified as complex patients with previous diseases. In these patients, in my opinion, and this is what we are doing, when lung ultrasound is positive, that means high probability, or intermediate probability, especially in the second allocation, so intermediate probability of the disease, we perform to all these patients CAT scan to understand what is going on. Of course, we perform also the swab test, but you must consider that the swab test needs time to be accomplished. The result of the swab test arrives after, when it is okay, after 12 hours or even 2 days. So it is not possible to stop the situation of the patient in isolation, waiting for the swab test, because there are not enough places to isolate anyone. So this is the reason why this protocol, guided by the combination of lung ultrasound and the phenotype, is crucial in the hospital.
Great. I thank you, Professor, for all these interesting points. I have some questions here for people from all around the world. And I would like to start with Dr. Javier Benitez's question, which I think is very interesting, and is the use of color Doppler to document shunt. Have you used this? Is this a feature that you can use? No.
I don't need a fine physiological and anatomopathological analysis of the lesions in lung ultrasound. We need something that is very simple, and I don't use it. No.
Okay.
I don't see the usefulness.
And another question here from Bruno Nascimento, I guess it's in Brazil, is what about the use of handheld?
Brazil? Which town of Brazil?
I don't know which town. I just see the name and I think he's Brazilian. He asked about.
It's strange because Nascimento is not a common name in Brazil.
Bruno Nascimento. I thought, well, maybe I'm wrong.
No. Nascimento is a common name there. I was joking.
Okay, so he asked about the use of handheld devices such as the Vscan and the Lumify. What do you think about this?
This is an important point. There is a lot of companies pushing for using small devices. I don't say the names, of course. There is one very famous and very popular. I need to be honest in this, because it is very important for patients and for colleagues. I don't believe a small device with not enough resolution of the image is as much useful as a ordinary device, carryable device with a good resolution of the image. I mean, we have, in my institution, we use both. We have a very small handheld device, and we have also the normal machine, the carryable machine. And I can say that at the beginning, we were using the handheld device a lot, because the idea was to reduce the possibility of cross-infection and to have something very handleable, very easy to carry on between patients and so on. But then, time by time, we abandoned the handheld device, because the resolution of the image is not enough. Because in this disease, what you need is to analyze with care the B-lines pattern, because there is a difference between the B-lines. They are not all the same. And there is a characteristic pattern of the disease that needs to be a very high resolution imaging, the pleural line, the regularity of the pleural line, and this kind of specific artifacts. So in my opinion, the handheld devices can be useful just to screen the patient very quickly. But then if you want to characterize the patient, especially in complex situations, you need a more high resolution image. And a good convex probe with a good machine is not possible to say that is not crucial. It is crucial. So if you have only the handheld machine, it's okay. Use it because it's okay. You will be performing a good examination. But if you can choose, for instance, you can choose to buy something new for your institution and you have the money, of course, please choose the more complex machine. Otherwise, you will lose something. Regarding the disinfection of the machine, there is no problem at all. It's a false problem. We are just disinfecting the machine like we do ordinarily. So we just clean the probe that we use with alcoholic solutions. Of course, we put more care about it. We spend more time to clean deeply. And then we use something to cover the keyboard, because the keyboard is the most sensitive part, of course, because of the irregularity. So we use a film, a transparent film, to cover the keyboard. And then in the ordinary situations, we just clean up the probe and nothing more. When you perform lung ultrasound in a situation with high risk of spread of the virus, like for instance, when you perform invasive procedures to the patient, for instance, intubation or bronchoscopy. In these cases, there is high risk of aerosol from the patient. And just in these cases, we clean up the whole machine. We have a procedure, we put outside the machine, and then we clean up the whole machine, including the screen and all the parts of the machine. But it's something that is normally done, and I'm sure there is much less danger of cross-infection than using in the standard way to all the patients X-ray facilities. They spread much more the infection than ultrasound.
Yes, this was exactly my next question. Patti Lopez did this question on how to clean up the disease, the ultrasound. Thank you for this. We have another question here from Ana Claudia Tonelli, and she's asking about if there's any recommendation after triage. I mean, let's say if there are any scan recommendations after you triage the patient, in follow-up of this patient.
My recommendation is not a recommendation, but it is a suggestion. And the suggestion is, first point, you need a hospital that is very well organized. And if you have not yet the outbreak, please think about that and start organizing in mind places, spaces for the patients. Even if you are in a quiet situation now, it will not last so long. And the organization is to have the possibility to move the patient from the emergency department as soon as possible. Just one moment. And to have the possibility for totally dedicated to COVID-19 patients, so only for those patients. And usually these units are the intensive care unit and the emergency department unit, where you can admit patients intubated and patients in a sub-intensive strategy of care. Then you need ordinary wards like pulmonology of internal medicine, with some area dedicated to COVID-19 patients in isolation, and areas separated with ordinary diseases, for ordinary diseases. But also an area that should be useful to admit patients with with a situation that is not yet defined, waiting for the response from the swab test. In some category of patients and some combination of lung ultrasound and phenotype, you need anyway to wait for the swab test. And it is very important to move away from the emergency department these kind of patients. So this is the general organization of the hospital that you need. Of course, in the emergency department, you need to have the possibility to isolate patients and to have a clean area for the other patients. This is, of course, mandatory. Regarding how to manage the patients after the triage, what I see is that most of the time, the patient do not need anything else than oxygen. Some patients will need CPAP ventilation, and only a minority of patients, but still a high number, minority in percentage, but high number because the number of patients are huge. They need intubation and ventilation, invasive ventilation. Those patients regarding invasive ventilation and CPAP ventilation, in my opinion, should be monitored by lung ultrasound to follow up the improvement and also to change strategy of ventilation if needed. For instance, we are using a strategy to make pronation in patients with CPAP ventilation. So patients awaken with a helmet, CPAP helmet. We put in prone position, but only reserved to those patients who show spread of the disease in the posterior lung. That probably are those needing recruitment maneuvers more than the others.
So do you use, this was a final question, Professor, any protocol to guide ventilatory strategies or titration in these patients using a protocolized lung ultrasound?
To be honest, it is not systematic because it depends on the, I don't work in the ICU, I work in the emergency department. Of course, I collaborate very closely with the colleagues in the ICU. Sometimes they continue the work that we start in the emergency department, but sometimes not. I would say that the tendency is just to use lung ultrasound only when the patient gives signs of deterioration. Usually these patients, they are in a steady state situation without improvement, and then they start slowly to improve. But some patients, they worsen the situation. And these patients are those worrying, of course, more. And in these cases, I see that they ask me to help to monitor by lung ultrasound to see if the score of lung ultrasound is decreasing, is worsening or not, and to understand if there are other conditions crossing, like for instance pulmonary embolism. We have a lot of cases of pulmonary embolism in these patients, or infection, bacterial infections, for instance, that can be detected by lung ultrasound. So monitoring has this way to be used usually. But I think that a very close monitoring, so day by day, should be the standard.
Great. I think it's always a pleasure to hear an expert, and I will not take more of your time, Professor. I think that you have a lot of work. We thank you very much for this very exciting and very comprehensive webinar that you have provided for us. And maybe you have any final remarks?
I thank you, of course. Do you work in Bogota?
Yes, I do. I work at the intensive care unit at Fundación Santa Fe.
Because I was in Bogota years ago in the pediatric cardio center. I don't remember exactly the name of the hospital. It's a very famous hospital. You understand which hospital?
I think it's the Fundación Cardioinfantil.
Fundación Cardioinfantil, exactly.
Yeah.
I was there for a course and a conference, and I have great friends there.
Yes, our colleague Gerardo Linares works very closely.
Yes, exactly.
Works very closely with us, and he's a very nice friend and colleague, and we work together in congresses that we hope you can join us sometime, Professor.
I have a great memory of Bogota. It's a wonderful place, really. I like it.
Thank you. Well, our house is your house. Whenever you want to come, you're most welcome here, and we hope that you can join us at Fundación Santa Fe soon enough. We thank you very much, Professor, for your help, and then I hope to see you soon.
Yes, thank you.
Okay,
Bye. Good job.
Thank you.